Shall we start, sir?
Yes, you can start.
Okay. So I request the attention of the faculties and delegates. I will take a few minutes of yours and let me introduce me and the faculty members of the session. Good evening and welcome to one and all. I'm Ankita from Clanet, the assigned session assistant for a seamless experience. And Clanet is India's most trusted and widely used digital platform with multiple enriching services exclusively for doctors. Clanet is very proud to be a digital partner for this event organized by Society of Anesthesia and Perioperative Care. And topic of today's session is Lecture Series 23. Let's begin today's session, for which I would like to invite Dr. Sohan sir to take over. Over to you, sir. Kindly proceed with your talk.
Hello and good evening to all. And I welcome you all for this 23rd session of SOPSI webinar. And today I invite Dr. Sukhada Savarkar. She is Associate Professor and she is my colleague in Tata Memorial Hospital, Mumbai. So I invite Dr. Sukhada Savarkar. Sukhada, please, you can start.
Thank you, Sohan sir. Good evening, everyone. So I really thank Dr. Anjali Pingle for giving me this opportunity. And this is a very relevant topic in today's age, especially when the incidence of cancer is only rising. And I'll just go straight to the topic. So the topic is, okay, can I share my screen? Yeah, okay. Yeah, so today's topic is anesthesia for hepatobiliary oncosurgeries. And the main goals and objectives of my discussion will be the main indications for liver resections as far as oncosurgeries are concerned, pertinent anatomy and the types of resections, the pre-operative concerns, pre-operative optimization, as well as intra-operative and post-operative concerns for liver resection surgeries, and also some controversies, some gray areas which are related to this part. So rather than just going quite theoretically, let's see a few case scenarios. I mean, these are the cases which we have done in our center. So maybe, you know, at the end of the discussion, maybe it will help us to see how, you know, how the management or the intraoperative or perioperative concerns changed as per the patient. So case one was a 39-year-old young female.
Ma'am, just a little interruptions, ma'am. Your
slides
are
not visible.
Yes.
Sorry, sir?
Your slides are not visible.
Not visible. Okay.
Just share screen again.
Yeah, I'm doing that.
Okay, now we can see.
Is it visible now?
Yes.
Yeah, okay.
Yes, yeah, now.
All right. So as I said, let's go through a few cases so that we get some idea about the different ways the patients present for liver resection surgeries. So the first case was a 39-year-old young female without any comorbidities. She was posted for left extended hepatectomy for hepatocellular carcinoma. She had no prior comorbidities, but the issue was that she was very nutritionally poor. Her intake was not good since the diagnosis of tumor, and her effort tolerance had decreased, probably because of the effect of cancer. So her albumin was initially 2.5, which increased barely to 3 grams. And she had significant weight loss. She had significant problems with effort tolerance. The second case was a 65-year-old male. He was diagnosed to have hepatocellular carcinoma, and he was posted for central hepatectomy. As far as comorbidities were concerned, he had chronic hepatitis C with compensated liver cirrhosis. He also had a past history of tuberculosis with post-tuberculosis sequelae causing restrictive lung disease, and he was on treatment for that for a long time. So his issues were chronic liver disease with decompensated liver cirrhosis and pulmonary issues. Third case was again a 65-year-old male without any known comorbidities. He presented to hospital with an infected liver mass with obstructive jaundice. On evaluation, he was also a chronic alcoholic, chronic smoker, and reformed since the diagnosis of this disease. On evaluation, he found out that he had hilar cholangiocarcinoma, which was invading the liver in segment 5 with infective abscess formation. So he underwent a lot of procedures. He underwent pigtailing for that abscess. He received a lot of antibiotics. Ultimately, when the mass was proven to be hilar cholangiocarcinoma, he underwent ARCP stenting to resolve the obstructive jaundice. And eventually, after 3 months of all this, he was scheduled for right hepatectomy with EHBT. EHBT is extrahepatic biliary tract excision. So his issues were basically an infected liver mass with a prolonged pre-operative history of infection, antibiotics, abscess formation. So probably inflammatory, a lot of inflammatory reaction inside. And plus he was an alcoholic, which caused alcoholic liver disease. So, generally in our Indian setup, probably patients do come up with, liver masses along with a history of pre-existing chronic liver disease, either because of alcohol or with viral hepatitis. So overall indications of liver resections, most common resection indication for liver resection is because of hepatic metastasis, which are arising from colorectal cancers. So it could be just a segmental wedge resection or a major right or left hepatectomy because of a big size of the metastasis. Also, it could be the other commonest indication is removal of the primary hepatic tumor like hepatocellular carcinoma or a biliary tumor like cholangiocarcinoma. It could be liver resection could be because of significant trauma to liver or because of benign liver tumors like liver adenomas or cysts or live donor liver transplantation. There could be segmental resections because of, because as a part of the hepaticojejunostomy procedure for injuries to bile duct, which are pretty high in location. There are a few indications for laparoscopic hepatectomies. They are less common than open procedures, but they are routinely done. Also, the robotic resections are done for isolated cysts or a small lesions, solitary metastasis, and very small hepatocellular carcinoma lesions. So as far as the liver resection surgical part is concerned, so initially it used to be anatomical resection. Now the surgical resection is more in favor of non-anatomical resection. What I mean by that is that the liver is divided into 8 segments based on the branches of portal vein. The liver is provided by portal vein, and blood flow is mainly by portal vein and hepatic artery. So based on the divisions of portal vein, the liver is divided into 8 main segments. And based on that, if we say the liver resection is based on the segments, it is anatomical resection. The advantage is that because it is delineated, the blood flow is delineated, the resection and the blood loss is, the resection is simpler, the blood loss is probably less, but the amount of healthy liver tissue which is removed is definitely more. What is non-anatomical liver resection is you remove the infected or the affected liver region because of the mass or because of the cancer, and you remove around 1 to 2 centimeters of margin around the liver mass. So it is a non-anatomical resection. The advantage is that the remnant healthy liver tissue is much more in this. The disadvantage is it is not according to the delineated blood flow. So the total blood flow might be more. The surgical techniques and the blood loss reduction of blood loss techniques must be applied to reduce the blood flow here. Okay, so the steps of the surgery will be first after opening. Now, initially it used to be a subcostal incision, which is called a lexus incision, but nowadays more and more surgeons are favoring another incision, which is called a Mokachi incision, which is basically a midline incision and an inverted L type of incision, a midline incision which goes from umbilicus till the abdominal wall, lateral abdominal wall. So it avoids the subcostal incision. So after incision, basically the first step is the mobilization of liver and mobilization, after which the cholecystectomy is performed. The ligaments, the triangular ligaments of liver are divided, after which generally, before taking all this inflow and outflow control, generally what will happen is the intra-operative USG assessment is done. prior in the pre-operative period, the CT and MRI is already done to locate the tumor and to see the vascular anatomy. But intra-operatively also an ultrasound is done, which is most of the centers, it is recommended and it is mandatory to confirm the pre-operative findings and to identify if there is any additional lesion, if there is any other cirrhotic element which is there. So after this, the parenchymal resection will start. First, the control will be taken, inflow control and outflow control will be taken, and then the parenchymal resection will start. During the parenchymal resection, generally the nowadays a CUSA technique, that is a cavitron ultrasonic aspirator technique, is used to disrupt the parenchyma, which will reveal the bile ducts and vessels, and then they will be either clamped or ligated. After the resection is over, the hemostasis part will be done, and then the abdominal closure will be done. Okay, as I said, the non-anatomic resection is nowadays more common because it saves the healthy tumor, healthy liver tissue. What are the anesthetic concerns? So you can divide it into pre-operative, intra-operative, and post-operative period. Pre-operative period, if we are talking about a normal individual without any comorbidities, without any addictions, the assessment should be according to any other major abdominal surgery, which involves pre-operative optimization of comorbidities, which involves prehabilitation. But if the patient has a pre-existing liver disease because of alcohol, because of hepatitis, then that assessment is absolutely essential before undergoing any major liver resection. Okay, because presence of chronic hepatitis or chronic liver disease definitely increases the risk for multi-organ dysfunction, definitely increases the risk for post-operative complications, renal failure, also hepatic failure in the post-operative period. Okay, so also one more important thing in oncosurgeries is the effect of chemotherapy on the liver. So there are advantages and disadvantages. So what are the advantages? It basically reduces the size of the lesion. It makes an unresectable tumor into a resectable tumor. It definitely improves the survival and outcome of the patient. It reduces the area of the tumor. So it reduces the area to be resected. It increases the residual healthy liver tissue. But it is also associated with complications. And two main agents which are responsible for complications is oxaliplatin and irinotecan. They are very notorious to cause steatosis, liver fibrosis, and it is quite prominently seen when the surgeons open the abdomen and they can see the effects of therapeutic agents, and it makes the resection difficult. It increases the blood loss, and it definitely increases the complications because of that. So the steatosis, hepatitis, the obstruction of sinusoids, and the fibrosis because of chemotherapeutic agents. Also, some agents may cause cardiac toxicity. So all these things also need to be optimized as far as possible in the preoperative period. So as I said, two main elements. Main is optimization and prehabilitation. Second is assessment of liver function. So if the patient has no pre-existing liver disease, then the prehabilitation part is very important. And in our setup, definitely we get a window of 2 to 3 weeks before the patient, actually comes on table. Right from the start, when he comes to visit the surgeon for the first time and when he comes on table, there is a window where we can use this prehabilitation to optimize the patient, to increase the functional status of the patient so that he can have a much better post-operative course and reduced post-operative complications. 2-3 main elements from the anesthesia point of view in prehabilitation are the correction of anemia, giving IV iron therapy and vitamin B12 therapy whenever it is indicated, cessation of smoking and cessation of alcohol. The data says that even as small as 24 hours cessation of smoking is beneficial, but at least a month of cessation is definitely beneficial for avoiding the complications because of alcohol and smoking. Third thing is exercise tolerance, increasing the exercise capacity, not only the pulmonary exercise capacity, but also the overall skeletal muscle capacity by doing physiotherapy preoperatively, so that the patient, the post-operative course is definitely shorter. these are the three things. And of course, the pre-existing comorbidity optimization, for example, diabetes, hypertension, etc. These are the four elements which we have to look into when we are talking about major liver resections. Second aspect is assessment of liver function, especially when we have a diseased liver before resection itself, right? So there are a couple of things by which we can assess the liver functions. One is in presence of chronic liver disease or cirrhosis, the standard scoring system is Child-Pugh scoring system and MELD scoring. And generally, the literature says that Child-Pugh C is definitely, unless urgent, unless it is absolutely life-saving, we should not go ahead with liver resections in child C. Child B, decompensated, again, it is not recommended, but in child A and compensated child B status, we may go ahead whenever it is essential. And as I said, it is oncosurgery, and there is nothing elective about oncosurgery. It is always going to be urgent and semi-urgent. So probably we need to see the risk benefit of not doing the surgery versus doing the surgery when it is a gray area, like, you know, child B status, decompensated child B status, etc. But child scoring is definitely one thing which we need to, you know, assess before the surgery. Two more things which they do is FLR, that is functional liver remnant. So basically by the CT and MRI radiological imaging, they will see how much of the functional liver will remain post-operatively. In a normal healthy adult without cirrhosis, without chronic hepatitis, even 30% of FLR is adequate for undergoing major liver resection. But if the patient has cirrhosis or liver disease, then generally 40% or 45% is the cut limit for going ahead with the surgery. If the FLR is, say, borderline, say it is 38 to 40%, sometimes we can increase it by embolizing the affected area. So if the patient, for example, if the patient has right-sided tumor and is scheduled for right hepatectomy, the radiologically, by interventional radiology technique, we can embolize the right portal branch. And after 3 to 4 weeks, we can again assess the FLR. If the FLR increases, then maybe we may go ahead with, liver resection after discussion. So the mechanism is basically by embolizing the right portal branch, we are increasing causing the hyperplasia of the healthy liver, which is the left side of the liver. And if that happens, and if it is adequate enough, we can go ahead with the surgery. So that is about functional liver remnant. One more thing which we can do is we can inject a dye called indocyanine green dye, and we can see the retention of the dye after 15 minutes. So basically it is excreted through bile and it is metabolized by liver. So impaired clearance of this dye is suggested when more than 15% of the dose, the injected dose, remains in plasma, metabolized dose remains in the plasma even after 15 minutes of injection. So that is another thing which we can do to assess the post-operative status of liver after resection, after major resection. So these are a few things which we can do. Also, we need to see other parameters, right? Like, the size of the tumor. If the size of the tumor is more than 4 centimeters, if the tumor is very closely located to vena cava, especially if it is posteriorly located, we can easily see that in the preoperative scans. Size of the tumor and the location of the tumor, because that means that to access the posterior location of the tumor, the surgeon will have to go near the vena cava. Surgeon will have to take the control of vena cava above the liver, supracaval control, and that is going to cause major hemodynamic disturbances. Third is the preoperative hemoglobin concentration. Fourth is presence of cirrhosis. One more thing which I forgot to mention is preoperative albumin as well. Right. So these are the preoperative concerns which we need to address, and then only go ahead with surgery. Also, there is one thing which we have at our center, I'm sure many of the centers have, is a high-risk joint session. So here the surgical team and the anesthesia team sit together and they have a discussion for, patients with major resections with a lot of comorbidities, and liver resections are ideal for discussions, in this group. So we need to sit together preoperatively, make a plan, and weigh the risk benefits before going ahead with the surgery. So this is probably the preoperative part. Intraoperatively, as far as the induction goes, I think general anesthesia, standard general anesthesia with endotracheal tube is the standard norm. As far as the choice of anesthetic agent goes, there are a lot of studies on inhalational agents, but most of the studies are done with halothane and sevoflurane and enflurane, and they are done on animals. And halothane is known to reduce the overall total hepatic blood flow. But the newer agents, sevoflurane, isoflurane, desflurane, they haven't shown hepatotoxic effects. They haven't shown any significant alterations. They are not, they don't cause effects like halothane. And as far as IV induction agents go, there is limited data. Not many studies are done with IV induction agents, but they seem to be safer as far as hepatic blood flow is concerned, because they do reduce they do cause vasodilatation, but they also maintain the hepatic blood flow by causing dilatation of splanchnic vessels. So it does maintain the total hepatic blood flow overall. So as far as the choice of agent goes, there is not much evidence to favor one particular agent significantly over any other agent. I think the goal remains the same, whether we are using inhalational or any agent or IV agent, that you need to maintain the cardiac output, you need to maintain the hepatic blood flow and MAP. Another concern is the effect of diseased, if the liver is already diseased and we are using drugs which are cleared by liver, metabolized by liver, then the doses and the timings of repeated dosage need to be adjusted according to the status of pre-existing liver disease. As far as thoracic, the pain relief part is concerned, of course, it is a major surgery, big upper abdominal incision, and pain relief is very, very important because it is going to affect the post-operative course. As far as epidural analgesia is concerned, epidural analgesia is a little controversial topic when it comes to liver resection, because there are many issues and concerns related to epidural. But still, there is no major evidence against using the epidural overall. The IRAS guidelines, which came in 2016 for liver resections, do mention that we need to avoid thoracic epidural anesthesia whenever possible, and we need to go in favor of abdominal wound infiltration or abdominal catheters whenever possible. But there is no standard evidence against using epidural. I think it needs to be tailored to individual patient, depending on the pre-existing liver condition, depending on the size of the tumor, the resection, age. Hello. Yeah, so we will come to the epidural controversy later. But so as far as the induction is concerned, I think standard induction with according to the patient comorbidities and endotracheal tube, and with or without epidural, depending on the patient factor, we should go ahead with that. Monitoring, standard monitoring. Apart from standard monitoring, I think if it is a major resection, we need to have a beat-to-beat arterial BP monitoring by putting an invasive arterial line, so that we also have a dynamic way of fluid management by using PPV. In some selective patients where patients have limited cardiac reserve, or patients really have very old elderly patients or very frail patients, or major liver resection, along with maybe liver resection patient needs nephrectomy or any other part to be removed, and in such patients maybe cardiac output monitoring needs to be concerned. If the patient has a chemotoxicity, cardiac toxicity because of chemotherapeutic agents, it is another indication for using cardiac output monitoring. As far as central line is concerned, Yes, in major resections, even again, IRAS guidelines and major centers do insert central lines. One for measuring CVP, seeing the trend of CVP, maintaining a low CVP. Second, if the IV access is very difficult because of chemotherapy, because of multiple prior procedures, then again, insertion of CVP is important. Third, for using vasopressors during intraoperative and post-operative course. And fourth, for giving parenteral nutrition in post-operative period if we are expecting a stormy post-operative course. So in those cases, central line insertion would be necessary. Apart from this, definitely we need to have major big wide bore IV lines secured, at least 2, because main thing which we need to do during the resection part is maintain the, control the blood loss and maintain hemodynamics. And central line, although it is important for, giving vasopressors, measuring CVP and post-operative monitoring, for blood loss management and fluid resuscitation, its role is probably limited because of the small size, small caliber of the bore of the CVP. So the CVP line. So we need to have a wide bore IV cannula in place prior so that we can have a rapid fluid resuscitation during the blood loss part. There have been reported cases of even 12 to 15 liters of blood loss during liver resection. So massive blood loss should be expected. And we need to, as an anesthetist also, we need to see the preoperative scans of the patient to see the location of the tumor, whether it is very peripherally located, centrally located, posteriorly located, whether it is very close to vena cava, whether it is very big in size, and that will give us an idea, what we are dealing with intraoperatively, whether we are expecting major loss intraoperatively. Also, one more thing is important for blood loss is presence of cirrhosis. Any patient with cirrhosis, the liver tissue is very, friable, and it is going to cause more blood loss, more than expected blood loss had it been a normal healthy liver. So that consideration needs to be done before starting the surgery, and we need to make a, plan of anesthesia along with the surgical team to, to decide whether outline is necessary, whether central line is necessary, what kind of lines, IV lines we will take, whether we will need to, initiate a massive blood loss protocol during the surgery or not, and what is the post-operative outcome that we are expecting. As far as the techniques of blood loss is concerned, apart from the CVP management, which anesthetists do, the surgical maneuvers, there are a few surgical maneuvers which are done. And the commonly done maneuver worldwide is a Pringle maneuver, where the surgeon will put a clamp over the porta to clamp both the hepatic artery and portal vein. So it is going to cause a reduction in cardiac output by about 10%. It is going to increase the afterload by 20 to 30%. And it is going to cause hemodynamic disturbances. So before doing Pringle, there needs to be a communication between the surgical team and anesthesia team. And the anesthesia team needs to be aware that the Pringle is going to happen, and it is going to increase the afterload, it is going to increase the MAP, but immediately after clamp release, it is also going to cause hypotension. So we need to be aware of these changes. If we are not aware that the Pringle is going on and suddenly if the BP is changing, we will not know what action to be taken, and that's why the communication will be important. There are many other, control methods which are mentioned in literature, but I don't think they are done very, very routinely. The routinely done maneuver is a Pringle maneuver, and there are two types: continuous Pringle maneuver or intermittent Pringle maneuver. So intermittent means you give a Pringle, you clamp the porta for about 10 to 15 minutes, and then you give time of reperfusion. You release the clamp for 5 minutes for reperfusion. So this is an intermittent Pringle maneuver. Continuous means that you continuously block the porta for say 1 hour or so, and the literature mentions there is no upper limit that is, the clear-cut upper limit that is mentioned, but generally the upper limit is 60 to 80 minutes for a continuous Pringle maneuver. The literature suggests that more than 120 minutes of Pringle maneuver is going to cause post-operative, definitely going to cause post-operative liver dysfunction. the cons for Pringle maneuver is that while we are doing this, we are reducing the blood loss, but probably we are increasing the the post-operative liver injury by causing hypoxic insult to the liver. But this intermittent Pringle maneuver seems to be safe, and the literature has not, does not suggest significant harm by doing intermittent Pringle maneuver. There is another method of occlusion is selective inflow occlusion. For example, if we are doing left hepatectomy, then we are the surgeon is only going to identify the left branch of portal vein and hepatic artery and selectively block that, which is not going to cause a lot of hemodynamic repercussions, and it is going to be much safer than a total total Pringle maneuver. That is one more way of reducing the blood loss. Another method is a total hepatic vascular exclusion. That means we are completely occluding or blocking the blood supply to the liver by blocking the vena cava also, and the portal vein and hepatic artery as well. And it is going to cause significant hemodynamic changes. It may, if we don't preload the patient, it is definitely going to cause even arrest if we are not careful enough in doing that method. I don't think a total venous vascular exclusion is done commonly in any center now, especially when we have advanced techniques of doing parenchymal resection, and you can safely do intermittent Pringle maneuver to reduce blood loss. So as I said, CPM and IPM, that is continuous and intermittent Pringle maneuver, selective inflow occlusion, they are the commonest methods to to reduce the blood loss, and the hemodynamic management in all these three techniques will be the same. It is going to increase the vascular resistance, it is going to reduce cardiac output, and it is going to increase the mean arterial pressure. So we need to be aware of these changes and accordingly manage the fluid and vasopressors during the surgery. On unclamping, definitely our goal needs to be to return the values to what were the what the normal baseline values were. During all this clamping maneuver, there will be the main source of bleeding will be from the backflow from the hepatic veins. So to reduce that, the commonly traditionally followed method is to maintain a lower CVP, classically less than 5. The guidelines, ERAS guidelines also mention to maintain the CVP between 2 to 5 millimeters of mercury. To do that, classically the IV fluids which we give, maintenance IV fluid, we need to limit the IV fluids probably. If still the CVP is remaining on a higher side, probably use of nitrates, use of vasodilators is advocated in literature. PEEP is to be avoided till the resection is over. The effect of PEEP on CVP is not very clear, but definitely giving PEEP is going to increase the intrathoracic pressure, and it may have effect on CVP. So avoiding PEEP till the resection is also mentioned. The problem with CVP is the CVP is not going to be reliable during certain maneuvers, like when surgeon is manually or mechanically pressing on the liver, or the retractors are applied on the diaphragm, and the retractors, surgeon is giving pressure on that, the CVP is going to go high. Also the level of transducer where we are fixing it is also going to have an impact on CVP. If the patient has restrictive pulmonary disease, if the patient already has a baseline higher right heart pressures, it is going to affect the CVP. So just maintaining and fixating on maintaining a single value of CVP, say, to just maintain the CVP to 0 or maintain the CVP to 2 is not going to be useful. Again, it is going to be individualized. We need to see the patient, we need to see the limitations of CVP and accordingly manage the CVP. Also, if the patient is very elderly, if the patient has uncontrolled hypertension or cardiac comorbidities, probably we need to look at something more than CVP, because CVP is not going to reflect the fluid status. A single number is not going to reflect the fluid status. While we are reducing CVP and reducing blood loss, probably the organ perfusion is also getting hampered. Although in all the patients, all the studies which are done in with using low CVP, the AKI or organ dysfunction post-operatively is not seen. At least significant AKI is not being seen. But all those patients or studies which were done, they were not done in patients with cirrhosis or patients with significant comorbidities. So when the patient has a pre-existing cirrhosis or other comorbidities, we need to probably alter our technique, and we should not fixate on a specific number of CVP. We need to see the whole patient and probably combine CVP with other modes of fluid management, like stroke volume variation, like pulse volume variation, and then decide the fluids rather than only CVP. So as I said, cardiovascular hemodynamic instability, increased risk of air embolism, because air embolism can happen during hepatic resection when the hepatic venules and small venules are open, and we are also maintaining a low CVP. We are also maintaining a lower BP to reduce the blood loss. So we need to be aware of these risks and then go ahead with maintaining appropriate CVP for that patient. So as I said, these are the various levels at which vascular occlusions are done during surgery. And this is fourth. Number 4 is a selective inflow occlusion, where they are selectively blocking the right-sided vessels to reduce the blood loss. Fifth is the total inflow block, where we are blocking the entire inflow, that is your portal vein and hepatic artery. 6 and 1 is basically taking control of vena cava, supra-hepatic and infrahepatic. And this is sometimes needed when, as I said, when the tumor is very close to the big vessels and very posteriorly located, where you have to lift the entire liver and take control, unless without which the resection will not be possible. And in that case, close communication is absolutely essential, because otherwise the anesthesia team will not know what is happening, why there is sudden hypotension which has happened. And before this cable control is taken, before that, preloading and maintaining a good hemodynamic intravascular volume is essential to avoid the consequences of this control. Right. So as I said, complete clamping of vena cava and portal vein together can cause significant hemodynamic consequences. It can reduce the cardiac output and venous return to up to 60%. Vascular resistance can increase up to 80%. And also along with tachycardia, but it is going to be a compensatory response. On unclamping, it is going to suddenly reduce the systemic vascular resistance, and we need to resuscitate the patient along with using fluids and vasopressors to bring the values back to normal. As far as renal function preservation is concerned, the patients with pre-existing liver dysfunction are at risk of post-operative renal dysfunction. Also, intra-operative fluid shifts, intra-operative hypovolemia is a risk factor for reducing the renal blood flow and post-operative renal dysfunction. That's why, as I said, when we are reducing the CVP and maintaining the CVP to near zero, we need to be aware of the effect on other organs. Many other drugs have been used to preserve the renal blood flow during using furosemide, mannitol, dopamine, but no significant evidence is found for or against these drugs. Terlipressin is an attractive drug which is now being used more and more to reduce the renal dysfunction post-operatively. We are in fact Dr. Sohan is in fact doing a study on that to see the effect of terlipressin on post-operative renal dysfunction. Maybe these are a few things which we need to look at to maintain renal blood flow to avoid renal dysfunction post-operative. Selective hepatic vascular exclusion, as I said, using only a selective branch of the liver to reduce the blood loss, and probably it should be the best method. And should be the method of choice when all other methods are probably not possible, when we can't reduce the CVP absolutely because of patient comorbidities, or because CVP cannot be lowered because of very poor cardiovascular status, or when patient will not tolerate because of cirrhosis, or tolerate a complete vascular exclusion. So that should be the method of choice in such cases. Air embolism definitely can happen during the parenchymal resection, because the parenchymal resection is going to cause opening of small venous hepatic venules, and we are already maintaining a low CVP, so the patient is at risk of venous air embolism. Probably giving a slight 10 to 15 degrees of head load during this procedure will reduce the risk of venous air embolism, and it is probably the risk of this is definitely more, as I said, when it is very close to IVC, when it is posteriorly located, and when we are using low CVP method. Okay, one more interesting technique which is being studied is the effect of preconditioning on ischemia reperfusion injury. So these clamping methods and Pringle maneuvers are causing ischemic injury and reperfusion injury because of the inflammatory response caused by the clamping. And ischemic preconditioning means you clamp the arterial and venous supply 5 to 10 minutes before the resection starts, so as to cause preconditioning and prevent the reperfusion injury. And there are studies, sevoflurane is one agent which has shown some positive effects in terms of ischemic preconditioning, but it probably needs more studies. So that is one attractive aspect which is upcoming now. Post-operative concerns, whether after a major resection do we extubate the patient on table or not, whether we electively ventilate the patient with major blood loss in ICU or not, the measurement of serum lactate, serial serum lactate measurements, in initial 48 to 72 hours, there is going to be an increase in the liver enzymes. There can be a spontaneous ascites, there can be coagulation abnormalities, there can be hypothermia, hypoglycemia. These are the main post-operative concerns. So as far as extubation on table is concerned, I think we need to look at each patient differently. What is the intraoperative blood loss, the temperature status of the patient, the coagulopathy of the patient, and the age of the patient, pre-existing comorbidities. And I don't think there is any specific contraindication to extubate the patient on table, even if there is major blood loss. But at the end of the surgery, if the patient is warm, if the perfusion is good, if there is no major acidosis on your blood gas measurements, and if the patient has adequate pain relief, that is also one important thing, then I don't see a major problem in extubating the patient on table. But as I said, there is no clear-cut indication or contraindication whether it is right or left hepatectomy. I think it again needs to be tailored based on the performance of the patient intraoperatively and pre-existing comorbidities. As far as increase in lactate is concerned, the lactate is metabolized by liver, and if the loss of liver mass is significant initially during the first 48 hours, the lactate is expected to be high. And the only concern is it should not be persistent, or it should not keep on increasing. The trend of lactate is important to see in the post-operative period. After any liver resection, the liver there is spontaneous hyperplasia of the normal liver tissue. It takes about 48 to 72 hours for that to happen, and for other liver dysfunctions to normalize, the liver enzymes to come back to normal, the INR and coagulopathies to normalize. So initial 48 hours, this stormy period is expected. But even after that, if there is persistently high lactates, persistently high transaminases, persistently deranged INR or platelets, then probably we are looking at liver injury and ongoing liver ischemia. So we need to be more vigilant if it is a persistent problem. Generally, it should be normalizing towards the end of 48 hours or so. Temperature management during intraoperatively also and postoperatively absolutely essential, because ultimately it is going to have an effect on the coagulation as well. Fluid management, the controversy again is whether to use a lactated ringer lactate or acetate solution or a normal saline. But again, whatever studies are done, normal saline is definitely known to cause hyperchloremic acidosis, and it is known to cause post-operative dysfunction, renal dysfunction. But as far as ringer lactate or any other balanced crystalloid solution is concerned, I think it is okay to use a balanced crystalloid solution. Then pulmonary complications post-operatively. Definitely it is a major surgery, upper abdominal incision is there, and patients are at risk of atelectasis, patients are at risk of post-operative infections. And pre-operative rehabilitation, intra-operative pain management, post-operative pain managements are very, very essential for avoiding post-operative respiratory complications. If there is a lot of handling, lot of inflammatory reaction during intraoperative period, patients are at risk of postoperative ileus. There can be spontaneous transient ascites because of liver dysfunction, because of significant liver resections. But generally, these complications do tend to normalize during first 48 hours. But we need to be aware of these problems, and if they are persistent, we need to evaluate and see what we are missing. If the liver is not recovering, if the liver is going into acute decompensated stage, then the patient is going to be probably going towards hepatic encephalopathy, and we need to see the changes in the patient. We need to see and detect the drowsiness, which is probably sometimes it is not very evident, but it is very gradual and subtle, and we need to be aware of these changes. We need to see what are the drugs which can complicate and which can confuse the post-operative status, and we need to eliminate, especially opioids or sedatives, and we need to eliminate them if we are thinking in terms of hepatic encephalopathy. Glucose control is another thing which we need to be aware of in post-operative period. And if we are obviously worried about hepatic encephalopathy and liver dysfunction post-operatively, then we need to investigate and do a close glucose monitoring and ammonia, serum ammonia measurements as well. In diabetics, in impaired, uncontrolled diabetics, also the tight control of sugar is not recommended now, but the initial 80 to 120 milligram of tight control regimen is not recommended now. Now, even the sugar control up to 180 to 200 is okay. Hypoglycemia can be because of liver dysfunction, and that we need to be aware of hypoglycemia. If the patient is requiring glucose supplementation post-operatively, we need to be aware that it could be because of decompensated liver disease. during the surgery and during the post-operative period, patient undergoes a highly catabolic state, and the patient needs to be resumed on oral nutrition as soon as possible in the post-operative period. Also, for liver regeneration, for replenishing the normal liver tissue, energy requirement is high. So as soon as we can, the oral nutrition needs to be restarted after liver resection. Generally, the coagulopathy after the liver resection, it peaks, say about at 48 hours, 24 to 48 hours, and it normalizes by post-op day 4 or 5. So unless the patient has active bleeding or unless the patient is cirrhotic, generally the INR and PT-INR comes back to normal range by post-op day 4 or 5. So generally transfusion of FFP or blood products is not necessary. It generally comes to normal values on its own. Again, platelet transfusion, the same rule. Generally, it will normalize on its own unless there is active bleeding or the platelet count goes below 10,000. Then platelet transfusion is indicated. Pain management, as I said, the gold standard is epidural analgesia for any open upper abdominal surgery. But yes, in liver surgery, it is a little controversial because liver surgery is known to cause coagulopathy, massive blood loss. And in post-operative period, the epidural management of epidural analgesia can be problematic. Removal of epidural catheter can be problematic. So we have to decide according to the each patient. In our center, there is no clear-cut contraindication. If the patient is posted for liver surgery, it is not a contraindication for liver, putting an epidural catheter. But yes, definitely we need to look into the coagulation, pre-operative coagulation status of the patient. We need to see the extent of resection. We need to see the other comorbidities of the patient, and only relying on PT-INR values probably is not completely adequate in liver surgeries. Probably we need to see the thromboelastography, the graph also, because PT-INR is only going to tell us about the status of the procoagulants in the blood. But there are many studies which do suggest that during liver resection or in chronic liver disease, there is hypercoagulability rather than hypocoagulability in blood. And so if you see the TEG graphs of these patients, the studies have seen the TEG graphs of these patients, and they do suggest a hypercoagulable graph rather than a hypocoagulable. So maybe the INR values may be high or maybe deranged or borderline, but if we do a TEG in these patients, maybe the graph is not at all suggesting hypocoagulability. So we also need an additional testing if we are in doubt, and then go ahead and decide whether epidural analgesia should be avoided or not. Short-acting opioids like fentanyl definitely is one of the mainstays of post-operative management. Especially we are not using epidural analgesia, opioids will be required for visceral pain management. But we need to see, we need to use the shortest acting opioids. We need to avoid long acting opioids. Also the intervals, if the patient is using PCA pump, the intervals of the boluses need to be increased, because repeated fentanyl administration in a patient with liver disease is going to, the fentanyl is going to accumulate in the body, and it is going to have prolonged effects, mainly the sedation and nausea, vomiting. NSAIDs, and as far as NSAIDs and paracetamol, again, paracetamol, even in cirrhotic patients, paracetamol can be given safely up to 2 grams per day totally. But as far as possible, we need to use the smallest possible dose of paracetamol in patients, and if possible, smallest possible dose, and also more than IV, we need to convert to oral regimen as soon as possible. NSAIDs again are going to cause imbalance of prostaglandins and prostacyclins, and it is going to hamper the liver blood flow in the post-operative period. So if we are thinking in terms of liver dysfunction, NSAIDs should not be given as far as possible. A few important predictors for post-operative complication is higher ASA classification, presence of steatohepatitis in the pre-operative period, the extent of resection, the size of tumors, the extrahepatic simultaneous resection of extrahepatic biliary tract along with hepatectomy, massive blood transfusion and massive blood loss. These are a few predictors of post-operative complications, and we need to give a real-time expectation to the patients who are undergoing these procedures beforehand, so that they are mentally and physically well prepared to face the post-operative recovery period. As far as controversies, the main first controversy is epidural versus abdominal catheters. And the advantages of epidural is that it definitely provides a superior analgesia. It definitely is the gold standard for open abdominal surgeries. It definitely helps us to reduce the, reduce the blood loss during the parenchymal resection because of sympathectomy. The disadvantage is that because of coagulopathy and massive blood loss, massive blood transfusion associated with liver disease, post-operative management of epidurals, the removal of epidural can be problematic. We may have to retain the catheters for more time, which means there is increased risk of abscess, increased risk of infections. And if we untimely remove the catheter, there is a risk of displacement. And if the epidural is removed when there is presence of coagulopathy, the risk of hematoma is there. So these are that is one major disadvantage of epidural catheter. Another problem, another controversy is that it can cause significant hypotension intraoperatively, and which may lead us to give a lot of fluids and a lot of vasopressors, which negate our goal of reducing the CVP. But as I said, it is not a hard and fast yes or no for epidural. I think as far as today's era is concerned, I think we need to tailor the need of epidural individually for individual patients, rather than saying no for all patients or yes for all patients. And abdominal catheters, yes, now with the advent of USG, with increased skill, increased availability, subcostal tap catheters, external oblique catheters, along with a rectus sheath catheter on the other side, definitely gives adequate and equal analgesia. Probably it doesn't give visceral pain, an analgesia for visceral part of the pain management. It will require supplementation with the use of multimodal analgesia, but definitely it is an option to epidural. Whenever we are in doubt, whenever there is a gray zone and we are in doubt whether to go ahead with epidural or not, yes, definitely, I think especially in liver surgeries, we need to err on the side of not putting an epidural and going away from Neuraxial whenever possible. Choice of fluid, as I said, I think avoiding a normal saline and giving any balanced crystalloid solution, I think, should be the goal. Perioperative, there is a controversy. Probably some centers do not give post-operative venous thromboembolism prophylaxis because of concerns of coagulopathy. But as I said, liver resections or cirrhotic patients, they do have a procoagulant state more than a hypocoagulant state. So perioperative use of venous thromboembolism is important. And management of CVP, whether to use CVP or SVV or PPV or what. I think there are studies where they have compared CVP versus SVV, and they saw that when the SVV, stroke volume variation of 20% or more, reduced the blood loss significantly when the SVV was maintained on a higher side at around 20%. It reduced the blood loss significantly without causing any post-operative complications. CVP, as I said, there are limitations to CVP in laparoscopic procedures. CVP value is limited when the retractors are being placed, or when there is mechanical pressure on liver. CVP role is limited. And again, CVP is a static parameter and stroke volume variation is a dynamic parameter. So probably I think we need to combine the knowledge of both and use it wisely to rather than going, maintaining 0 CVP or 2 CVP. I think we need to see the patient and also look at the resection, the operative field, and decide what is happening. And really we can see the blood loss, increasing blood loss, increasing oozing when if we see that, definitely, and if the patient allows, definitely maintaining CVP on a lower side is going to be beneficial. These are my references. So if we go back to our patients, 3 patients, sorry. Yeah, so the first patient was a young patient. She was posted for left extended hepatectomy. No other comorbidities here. I think the issues were in the pre-operative part, the part of the anesthesia management. She needed rehabilitation. She needed nutritional supplementation. She needed respiratory, and she needed improvement in exercise capacity, and we did that, and after that her albumin, pre-operative albumin was I think 3.2, and she suffered a blood loss of I think 1.5 liters, and her post-operative course was fine. So I think her issues here, the issues were in the pre-operative optimization. We needed to optimize the patient pre-operatively, and rehabilitation was important in this part. In this patient did have major comorbidities. He had pre-existing liver disease. He had pre-existing pulmonary disease. This patient did have a slightly borderline APTT. His INR was normal. INR was 1.25, but APTT was ranging in 38 to 39, if I'm not wrong. So we did a TEG, and the TEG value was absolutely normal. 38 was a borderline value because it was less than 1.5 times the normal value of APTT. But we were still concerned, so we did a TEG, and the TEG was normal. TEG did not indicate any high, coagulopathy in the graph. So in view of the restrictive pulmonary disease, we did go ahead and put in an epidural catheter for this patient. We also did insert a central line and arch line, and did a cardiac output monitoring for this patient for maintaining the fluid status and managing blood loss. Third patient, again, a 65-year-old male, no comorbidities other than a chronic alcoholic status, because of which he had a pre-existing liver disease. Although he was not cirrhotic, but he did have significant steatohepatitis. Also, he had a prolonged pre-operative course in terms of pigtailing and ERCP and antibiotic course. And during intraoperative period, there was a massive, there was significant fibrosis while doing the resection. Before the resection started, there were a lot of adhesions just to have access to the tumor, mass. So the patient did have a significant blood loss, about 4 to 5 liters, but more than 80% of the blood loss was before the resection started, before they in fact started the parenchymal resection, because of this adhesions and systemic inflammatory response which he had because of his preoperative status. So this patient had inflammatory response, adhesions, and that's why he suffered a significant blood loss and fluid shifts. The resection part of the actual tumor was uneventful. It did not have much blood loss. So I think each patient that presents to us with any liver mass or liver cancer, I think we need to see the 2 elements, that is prehabilitation part, and second is the pre-existing liver disease part. And the pre-existing liver disease part is absolutely essential to evaluate further if we find a laboratory evidence of liver disease. We should not ignore it. We need to evaluate further to see if we can modify it and solve it, rather than accepting the minor or mild dysfunction of a liver. Because post-operatively, it is going to have major outcome, major profound effect on the recovery. Thank you.
Thank you, Sukada, for a detailed and comprehensive talk on like liver disease, how we manage hepatectomy, intraoperative and post-operatively. So we have a few questions in chat box, and I think we should try to cover as many as possible. So like there's one question from someone. They said, how do you manage 3 to 5 times rise in liver enzyme post-operatively? So you want to give the answer?
In the post-operative period?
Yeah. So if there's a some like increase in from 40 to maybe 120 or 160 or 200 maybe.
Right.
Yeah.
So yes, in any liver resection, whether small or big, there is an expected rise in the liver enzymes, which is expected in the post-operative period, especially in the first 48 hours. It is, and if it is a major resection, like like a right hepatectomy, the rise is 3 to 5 times sometimes it is much more than that as well. But I think we need to give it time to recover, and we need to see the trend of it rather than just getting worried because the value is too high. I think we need to wait and see what is happening to the values in the post-operative period in the first 48 hours. If they're persisting, or say if the first post-operative day it is high and the repeat value is even higher than that, probably then we need to think whether that the liver is not recovering, and probably we are looking at a decompensated liver state, and at that time probably a surgical consult is also essential. Venous Doppler, a hepatic Doppler is also essential to see whether the blood flow to the remaining liver is adequate or not. We need to see whether the hemodynamic volume status is adequate or not, and then go from there.
Yeah, you're right. Actually, if they like after hepatectomy, some amount of rise in the liver enzymes are almost always there. So we should not be worried like acutely on this, but we have this some persistent increase, then we have to worry, and then we have to look for causes and all these things. So to go to the next question. So next question is like, what colloid do you prefer intraoperatively, and what percentage of albumin do you use?
Okay, so intraoperatively, during the blood loss part, I think if the blood loss is really massive and we need to rapidly give fluids, I don't think it matters what kind of fluid we are giving, whether it is really RL or NS or a gelatin or albumin. I don't think it matters, because our goal is to maintain, at that point of time, is to maintain the intravascular status. And if the intravascular volume is less and the hydrostatic pressure is less, whatever fluid we are going to give is ultimately, if the blood loss is active, it's not going to stay in the system. So during the blood loss part, I think maintaining the volume is important rather than the choice of fluids. Once the intravascular volume is replaced, and once the volume status is adequate, and further if we need, and if the patient is still hemodynamically unstable, we are giving vasopressors and still the PPV is high, suggesting the use of, we need to give some fluids, probably there is a role of colloids, and that time we need to use colloids. We generally use a combination of gelatin and 4% albumin. 4% albumin we use when we are, when we need to give rapid fluids rather than giving a slow fluid for maintaining the volume. So 4% albumin is generally used during intraoperative period, and gelatin. And gelatin, I think 20 to 30 ml per kilo. More than that, I think we are not using. But it's a combination of both gelatin and 4% albumin during the intraoperative period. And especially if the patient had a pre-existing lower albumin status, which was not corrected, probably then there is a more role of albumin than any other fluid.
So actually, there are some studies like which they use this acetate and the maleate base of the like balanced salt solution, but there is no clear-cut benefit of giving those like costly fluids intraoperatively. So we are okay for by giving like even that this RL intraoperatively, and for colloid, like colloid we mostly use albumin as a proportion. But yeah, that's the gelatin can also be given whenever like you want to give some colloids. So
Right.
next question is so do you supplement phosphate in the post-op period, and in which patient do you use, and what dose do you use? So you have an idea of phosphate in post-op period?
Immediate post-operative period, unless the patient cannot be resumed on oral supplements as soon as possible, unless the patient has a significant ileus, which necessitates use of parenteral nutrition. I don't think we routinely supplement phosphates, but I think maybe you are in a better position to answer that. I don't think we routinely supplement it.
Yeah. So there are some reports and some studies that say like a post-operative hypophosphatemia are there after hepatectomy and even after like some like Whipple surgeries in some cases. So they are maybe either because of some this positive fluid balance or whatever thing, and especially they are more common if the liver is going into like some failure type of condition in the post-op period. In that cases, like they say,
Okay.
if the giving phosphate can be a benefit. About the dose, I'm not sure what dose we give, and I personally have given the phosphate because I don't do much post-op IC, but so. So in that cases, we can
Right.
give phosphate, especially.
Okay.
So what question? Yeah. So do you use LMWH the prophylaxis for these patients?
Yes, we do give pre-operative and post-operative LMWH prophylaxis, mainly enoxaparin, and it starts in the pre-operative period. We give it 12 hours prior to the surgery, a prophylactic dose, and in the post-operative period, as soon as the surgical field is satisfactory, the drains are satisfactory, we do start LMWH prophylaxis in the post-operative period as well, in hepatectomy surgeries as well.
Okay. Yeah. Thank you. So it's a clear answer.
And yeah, as I said, it is a controversial. There are some centers which do not use post-operative LMWH, but because the studies, whatever research has been done, liver surgeries patients are at higher risk of embolism, venous thromboembolism, because of the complex nature of procoagulant and anticoagulant balance in these patients. I think it is indicated, and the guidelines do suggest using it.
Okay. Then next question is regarding the 30% study. What is inclusion criteria? So inclusion criteria, I will tell you. So we use 30% study. Like we include only patients which are going for a major hepatectomy, means at least 3 segments are going to be resected, or if they are going to do up this posterior sectionectomy, and we take like ASA 1 to 3 patients and like all adult patients we take. So the major criteria is that there should be a liver tumor and going for a major hepatectomy. So that is the inclusion criteria. The next question is that at your center, do you manage cases without central line safety monitoring? How do you select the patients? So Shubhita, you want to take?
Yeah. So as I said, I think seeing the apart from the comorbidities and liver status, seeing the pre-operative scan is absolutely essential. If it is a very difficultly located lesion, or it is very close and posteriorly located, it is that does mean that it is going to cause hemodynamic problems. It will necessitate the need of vasopressors, and it is going to probably have major hemodynamic problems intraoperatively, and having a discussion with surgeon is also important. I wouldn't say we insert central lines for all the hepatectomies. If it's if it's a small lesion, where surgeons are not worried about massive blood loss, and if the IV access is adequate enough to manage the blood loss and to give rapid fluid resuscitation, and we have other means of maintaining fluid status, like PPV, like IABP and PPV management, the dynamic fluid management, means, then the central line is not necessary in all cases. We don't insert central lines in those cases. But where surgeon is worried that the patient, cable control is going to be, necessary intraoperatively, or the patient is significantly having a pre-existing liver, cirrhotic liver status, in such cases, or venous access is difficult, yes, central line insertion is important, and maintaining a lower CVP. If we are going to plan to maintain a lower CVP in hepatectomies, yes, inserting central line is important. I think you can also share your experience, sir.
So, so if we talk about the central line used in hepatectomy, so roughly we use central line in 1 in 3 patients. So around 35% cases, 35% time we use central line. Like today, I use central line in liver cases. But normally, like in 2 out of 3 patients, we mostly do not use. And if needed, we sometimes use intra-op also. Like if the patient is going in unexpected major blood loss, then we use intra. But CVP monitoring, we are definitely not doing CVP monitoring, because many studies show that there is no role, or there is some dubious role of the CVP during the hepatectomies. And even the studies, they have done like low CVP versus normal CVP, and there was no benefit, clear-cut benefit in terms of the like blood transfusion and the post-op mortality and morbidity. So they say the role of CVP, like low CVP, is not there, at least in current practice. So we use, even if we put central line, we mostly use for giving the vasopressors and not for monitoring CVP. So we go for the next question. The role of IV albumin in liver resection is there, 5% or 20%. So I think we already answered that. We mostly give 4% albumin. Some people give 5% also, but 20% mostly we do not give unless like you are worried about the pre-op low albumin and something like that.
Yeah.
But normally intraoperatively we don't give 20% albumins. The next question is that noradrenaline versus vasopressin use intra-op, any factor to guide choice?
So I think routinely in our center, we are using noradrenaline as the vasopressor of choice. And as sir said, recently we are doing a study on terlipressin as well. But vasopressin, we are not
normally do not use. I think,
not
and there's no much literature also on using vasopressin.
No studies suggesting the benefit of it versus noradrenaline.
So that vasopressin, this terlipressin we are like using to prevent the post-op like AKI, something like that. But we'll see when the result will come. The next question is, if the patient has well-controlled chronic hepatitis B on treatment, what FLR cutoffs should you consider?
So in the presence of already pre-existing controlled hepatitis, that means that the patient has a pre-existing liver disease. I think a FLR cutoff generally, which they consider, is around 40%. In a completely healthy patient, probably it is less than that. Probably 30% is also enough. But in a diseased liver, at least 40% should be.
In those cases also, like we have to see like if they are going to sacrifice the middle hepatic vein or not. So like your FLR should also be like MHV preserving FLR or MHV sacrificing FLR. That we also to see in these cases.
Correct.
So like in a normal healthy liver, you just told that your 29% or 30% FLR is also good. In a cirrhotic liver, you need much higher FLR. So it all depends on what case to case. The next question is, this is a comment for the first okay. So
it is a comment on the first question, actually.
Yeah, so Dr. Vandana Agrawal, they commented that if the liver enzyme continues to stay elevated beyond post-operative 5, the indicator of post-hepatectomy liver failure and the life. So yeah, that's correct. And is there any role of N-acetylcysteine as a protective agent intraoperatively?
So I don't think there is any evidence which is clear-cut, showing a clear-cut benefit of using it intraoperatively. And we are not using it intraoperatively as a routine
Yeah,
measure.
Actually, so we don't have any like idea or any experience of giving introp and neck. But yeah, if anybody has given, they can
Yeah.
comment. But, we have not used intraoperatively in any patients. So, is there any question on that? Any more questions from anybody? Yeah. So if there is no question from anybody, like then we would like to stop this session right now. And I thank Dr. Sukudha Savarkar for a detailed and very good talk on the management of the liver surgeries, especially the liver cancer surgery. So thank you, Dr. Sukudha, and thank you
Thank you,
all the
sir.
audience for joining today. I hand over to Ankita. Ankita?
Yes, sir.
Yeah, you can.
Yes, sir. Okay.
Yeah. Mm.
Thank you so much, everyone. Thank you for your valuable insights. Hoping to meet you again on this platform very soon for the next sessions. So with all your permissions, we are signing off for today. Thank you.
Thank you.
Thank you.
Thank you all. Thank you.
Thank you.